Our next session is Focus Session 2. I would like to request the panelists to take the seats at the dais, please. The panelists are Dr. Untitled Chatterjee, Dr. Dhritobroto Das, Dr. Achyut Sarkar, and Dr. Anil Singhi. I would like to request Dr. Vikas Kohli to enlighten us on a case of tetralogy of Fallot. Dr. Vikas Kohli.
Good afternoon, everybody. We have amongst us three very eminent pediatric cardiologists. I'll introduce them in the sequence that they are sitting here. Dr. Dhritobroto Das, Dr. Anil Singhi, and Dr. Achyut. They're very well known to all of you, and I've had the opportunity to work with Dhritobroto, and Amitabh is on the way because of an emergency case. He'll take a few more minutes to come. I'm thankful to the organizers for bringing up this session on tetralogy of Fallot. Just a few words about tetralogy of Fallot. This is the first cyanotic heart disease which was operated. This is the first congenital heart disease which went under heart-lung bypass machine, 1952, Dr. Lelehai. And that patient is still surviving, one of twins. And every single cardiologist gets to see a tetralogy, and pretty early in their career. What is important is, tetralogy is a condition which has reached practically nearly more than 95%, if not more than 98% survival. Today we are not talking about survival. We are talking about longevity and avoiding late interventions. This session, which we are going to talk about, is to bring forth the contemporary assessment of anatomy with a view towards what surgery would be done finally. We all look at the anatomy, but not necessarily with the view of what surgery would be done. And once we are aware of that also, we demand that kind of surgical outcome for our patient so he doesn't get into trouble 20 years later on or does not die from late arrhythmia. So the areas we'll be covering is introduction, followed by anatomy, echo assessment. This is only an echo session. We are going to talk about echo images only. We'll talk about four main areas: VSD related issues, RVOT related issues, coronary artery related issues, other variations of tetralogy of Fallot which are very important, and then we'll have discussion. What we will not cover is at what age and weight the surgery is to be done, because that's surgeon specific and that is specific to institutions, though we are aware of it in the literature. We will not be going into late and long-term outcomes. We will be focusing on echo for diagnosis with the surgery in view. Focus will remain on echocardiographic assessment. Now 100% or nearly 100% of patients of tetralogy will undergo surgery. Almost 20% of them, if the surgery is not done right in 20 years, 2 decades, will require a re-intervention. How can we suggest the surgical plan to the surgeon in a way that the surgery is done right and the re-intervention rate is lower? So we all know the four components of tetralogy of Fallot: RVOT obstruction, thickened right ventricle, ventricular septal defect, and aortic override. This is exactly not what we are going to go into. We'll go into the echo assessment of all of these, but I'd like to bring forth an article in 2005 by Dr. Ed Bovey, who is an icon in pediatric cardiac surgery, defining it. This article, incidentally, is in Operative Techniques in Thoracic and Cardiovascular Surgery, and he published this in 2005. The article is entitled Transatrial Repair of Tetralogy of Fallot. And one of the lines he highlights, which I've brought forth, is the approach of avoiding or minimizing right ventriculotomy during the repair of tetralogy of Fallot has been utilized for many years. As long as long-term sequelae have been studied, it has become apparent that right ventricular dysfunction, due at least in part to the right ventriculotomy used to close the VSD and relieve the outflow obstruction, has emerged as an important cause of late problems. So today, RVOT repair is practically done without an RV incision, unless one particular part of it is required. So years back, this is what used to be done. Decades back, this is what used to be done. The VSD would be closed from the RVOT incision. Today, the VSD is closed transatrially. There is practically no ventriculotomy done. The ventriculotomy could be as small or smaller than this for a small annulus. And if the VSD is extending towards the pulmonary valve, you need to take a few stitches from the pulmonary artery, transpulmonary VSD closure. Also, few stitches at the upper end may need to be taken. So this is what the surgeon needs to know. And about RVOT resection, the muscle below the valve can be resected transatrially, avoiding any RVOT incision. So we don't need to incise the RV to remove muscle from the RVOT. The annulus needs a transannular patch, which may need a RVOT incision, which may be 0.5 centimeter only, and should be the smallest size possible below the annulus. Above the annulus, you can extend the patch into the branch PAs, and that's not going to make a difference to the long-term outcome of the patient. The long-term outcome is dependent only on the incision in the RV muscle. And it's the arrhythmia and reintervention for pulmonary insufficiency which get affected, and these two are the main issues. So when we discuss each aspect, we will be keeping in focus the issues related to this. But we will not start from a high end of VSD related to tetralogy or to RVOT. We'll start with the basics. So, Dr. Dhrito, this is all yours.
So, VSD in tetralogy of Fallot is most commonly perimembranous VSD, but because there is a deviation of the anterior conums, so it is malaligned VSD as well. So, classically in tetralogy of Fallot, it is a malaligned subaortic VSD. It is usually a perimembranous VSD just below the aortic valve.
What are the other variations, Dhrito?
Now, perimembranous VSD, sometimes it can extend into the muscular septum, especially the inlet septum, and there may be additional VSDs also. Sometimes the VSD can extend into the towards the pulmonary valve, and the whole of the infundibulous septum may be absent, and we call it a doubly committed VSD, a subpulmonary VSD. So, in these cases, the VSD is both below the aortic and the pulmonary valve. So, there is no conal septum at all. Very rarely what can happen is a restrictive pulmonary restrictive VSD, which is very rare, but sometimes the tricuspid valve tissue, either it may be the valve tissue or accessory tissue below the valve, may project into the ventricular septal defect, and it can partly obstruct the VSD flow, and the surgical risk will be much higher in these cases. And inlet VSD is usually more common in the tetralogy with a complete epicanal group, but sometimes it can be without a complete epicanal also. But if it is associated with complete epicanal, usually they are trisomy 21, most of them. This is a picture where you see an additional VSD. This is very important to look for additional VSD in tetralogy. This is more important before we plan the surgery, because when we jump into a diagnosis that it is a tetralogy Fallot, commonly what happens, we see a overriding large subaortic VSD and RVOT obstruction. We know the diagnosis is tetralogy of Fallot, but that is fine. But for pre-surgical assessment, you need to look for many other things. One of them is whether there is any additional VSD or not. This is difficult to find out these VSDs because both the RV and LV has almost equal pressure. So the flow is not a high velocity flow, and it may be bidirectional, as you see in this picture, and I think in the next picture also we will see that there is a bidirectional flow through the VSD. And the echocardiographer's point of view, it is very important that you reduce your scale and then look throughout the septum from the apex to the base of the heart, so that you don't miss any small or maybe sometimes large muscular VSDs also are missed unless you specifically look for it. This is a picture of inlet VSD. This is a complete AV canal, as you see, a common AV valve, and you can see that there is a large inlet VSD and primum ASD as well. So this is a tetralogy with complete AV canal. Now, doubly committed VSD, as I have already mentioned, normally it is a perimembranous septum. So when you look at the VSD from the short axis, usually the VSD will be between 9 to 11 position. So that is the classical location of the perimembranous VSD in the short axis view. And you will see that there is a conal septum which is separating the VSD from the pulmonary valve. But if you find that the VSD is extending from 9 o'clock position to maybe 12 or 1 o'clock position, and you don't see any infundibular septum below the pulmonary valve, then it is a doubly committed VSD. So it is more common in our subcontinent, because in the western population doubly committed VSD's incidence is much less compared to the Asian region. And from the surgeon point of view, it is also very important because there is no obstruction below the pulmonary valve. So there is no infundibular obstruction. You cannot mention that it is a tetralogy with a doubly committed VSD and there is infundibular PS. That's theoretically not possible. And from the surgical point of view, it is important because when they are putting stitches on the aortic side or the pulmonary side, there is very little tissue. So they have to stitch it almost to the annulus. So that is important to mention that it is a doubly committed VSD from the echocardiographer, so that the surgeon knows it beforehand planning the surgery.
The conus septum.
Yeah, so what I was mentioning, if you look at the VSD position is almost 9 to 11 o'clock, and you can see that you can see that there is a conal septum which is deviated towards the anteriorly. So this is the conal septum which is deviated anteriorly. This is the classical abnormality in tetralogy of Fallot, and sometimes it is called the monology of Fallot, but because this is the only problem which creates all the other problem. Because this conal septum is anteriorly deviated, that the reason there is a malaligned VSD, the two septums had not come at the same place, so that has created the VSD. And because the conal septum is anteriorly deviated, so you can see that there is a turbulence across the infundibular region, and that is the cause of RVOT obstruction. And the rest of the thing is a sequelae of this the main problem. So it is also called a monology of Fallot, this anterior conal deviation. And sometimes what happens in newborn babies, because the pulmonary vascular resistance is high, so you may not find a turbulent flow across RVOT. But you see a large VSD, similar kind of anterior conal deviation, often they will turn into a tetralogy as the baby grows. So you have to be very careful and mention that it is a malaligned VSD with a deviation of the anterior conal septum. And you have to keep in mind that during follow-up, check for there is any appearance of the RVOT obstruction.
Wonderful. So you think embryologically this is the key reason why the four things always happen together?
Exactly, that's one of the theories.
And when you have to differentiate a VSD pulmonary stenosis from tetralogy, what would you use to differentiate?
We will not expect an anterior conal deviation and the infundibular obstruction if it is a VSD with pulmonary valve stenosis. And because this is the anterior conal deviation is causing the infundibular obstruction in case of tetralogy,
so
which will not be
present.
So
this is the sine qua non of tetralogy of Fallot.
Exactly.
Okay, very good. And what about residual VSDs?
Yeah, this is one of the common problems. Often these residual VSDs are small. It can be on the side of the patch, or there may be a muscular VSD which has not been properly assessed before the surgery, or sometimes a small VSD the surgeons are unable to close also. So residual VSDs can be either around the patch or it can be in somewhere else in the septum. If it is in the patch, it is more difficult if it is towards the aortic valve, and that is the area where stitching is difficult. When you are doing a transatrial repair, you are basically stitching through the tricuspid valve, and that is the reason that most of the residual VSDs are on the aortic or pulmonary valve side.
And also that is a reason surgeons open the pulmonary artery in all cases and take the final stitches at the upper end of the VSD through the pulmonary artery so that there is no residual VSD. So why, any one of you could answer this, why do you think residual VSDs cause such a big problem in tetralogy of Fallot?
Yeah, because the RV is already stiff, and it is more used to handle a high pressure. So when there is a chance of diastolic dysfunction, especially in the postoperative period. So when there is a residual VSD increased left to right shunt, the RV usually have more problem to handle the extra flow.
Right, and also if it's at the upper end of the patch, it's an outlet VSD, even a small VSD can result in huge shunt because previously the lung is not used to so much volume, it won't be able to handle it, and that will make it worse. So one actually has to be obsessive about making sure you're not bringing a patient out of the operation theater with a residual VSD after tetralogy correction, because that's the patient who will get stuck in the ICU for a longer period of time and could increase your chances of prolonged ventilation and therefore even of mortality, or of reintervention subsequently, or of patch dehiscence, all of these things that we get to see.
Sir, just a comment. In fact, residual stenosis,
Yes.
residual VSD is more detrimental than residual stenosis.
Absolutely, absolutely. And that's a very good point, and we will get back to this if any of you have questions. Why residual stenosis is better than residual VSD, you could bring it up in the discussion phase. That's a very good point. Drito, just a word about DORV and how do you differentiate, and when would you say it's DORV?
This is a common question. So whenever you do a echo, that whether it is a tetralogy or it is a double outlet right ventricle. Because the most commonly how we decide that whether there is a 50%, more than 50% override or less than 50% override. If it is more than 50% override, then you think that the aorta is mostly committed to the right ventricle, and that's it is a double outlet right ventricle. From the hemodynamic point of view, both it does not have much difference, but it is important to reach a diagnosis when you are writing the echo report. But this 50% override or less than 50% override is more of a subjective thing. If you change the angulation of the probe, how you are holding it, if more than 50% can become a less than 50%. So it is not recommended to go only by the 50% or more than 50% override. It is more important to look for whether there is a bilateral conus. So you should look for whether there is a aortomitral discontinuity. So normally the aortic valve and the mitral valve is in the same fibrous ring. So there is a continuity between the anterior mitral leaflet and the aortic valve leaflet. But if there is a tissue, there is a muscular tissue below the aortic valve, then it separates the mitral valve and the aortic valve, and that is called subaortic conus, and that is pathologically the hallmark of double outlet right ventricle.
Which view would you recommend the audience to look?
It is in the long axis view, the standard long axis view, where you see the mitral valve and the aortic valve together.
Right. Because of time issues, we are continuing, and we will be talking next about the right ventricular outflow tract, which is the second most important aspect of tetralogy of Fallot. And I'm sure we all have seen several cases, but here we are going to dissect it bit by bit. So, Dr. Amitabh, we are glad to see you here. I hope everything okay with your patients.
Yes, I had an HLHS who came in emergency, so I had to manage it.
Yeah.
Sorry for that.
We understand. You live for your patients. So, RVOT obstruction in tetralogy. Where all can there be an obstruction in the RV outflow tract, Amitabh?
The RV outflow tract, if we start from the very apex one, it can be a double chambered right ventricle, it can be in the RV mid cavity, and again above that one, above the infundibular chamber, the commonest one is in the infundibular region, that is the region just below the valve, followed with at the valvular level, and followed by at the supravalvular level as well, and even in the branch pulmonary arteries. So throughout the whole of the tract, there can be several variants where there can be an obstruction.
And where is the typical obstruction?
The typical obstruction is the infundibular, by definition infundibular, and the valvular level, because the valve itself is dysplastic and smallish.
So valve you would differentiate into leaflets and annulus.
Yes.
Okay. And annulus measurement and Z-score, why are these two important?
These are standardized methods, because what might be a small valve to someone else might not be a small valve to me. So these are an international standardized methods by which we go to see whether the valve needs a transannular patch, whether the surgeon needs to cut open the annulus so that to enlarge it to for a transannular patch, or the valve can be spared. This is one of those. And the other thing, and the other place is, if we do not standardize, then the valve measurements might be different at different ages. So the standard Z-score of -2 to -2.5 is taken as below par for age and sex of the child.
Would you recommend a website anyone can go to and check anytime?
Yes, it's a Z-score website. It is standardized all over the world. You can check it anywhere. You can even download on your Android phones.
Parameters.com, the parameters S is replaced by a Z. Parameters with a Z.com. And it comes as an app also, and you can put in the number you have and the age of the patient or body surface area of the patient, and you will get the Z-score. So why this annulus size is important? because if it is below minus 2.5, the surgeon would need to put a transannular patch, and the late and long-term outcome branches off to 2 based on whether there is a transannular patch inserted or not inserted. And that's the key differentiating point for late and long-term outcome. And how the patch is inserted, that's also important, how big it is. So we've talked a bit about the RVOT obstruction repaired. Just a comment about what you see on the image here. So this is, we've tried to show the length of the RVOT, including the subvalvar, valvar, and the proximal MPA.
And the valve itself. In this particular view, the valve is plying, and there is some amount of infundular obstruction, as well as there is some amount of obstruction just above the valve. That is, a suprafloral component is there.
Can I get a pointer, please? Sorry for interrupting. Can I get a pointer, please? Go ahead.
So in this case, we need to take the valve annulus in a still picture and measure it with the z-score, whether the valve can be spared or not. If the valve can be spared, that saves a lot of hassles for the child, because they will be spared of the pulmonary incompetence, which will spare the future prospects of pulmonary valve replacement. If the transannular patch is spared, if the valve can be kept. Otherwise, we'll go for a transannular patch repair, including, whatever patch the surgeon prefers in that particular institution.
So in this one single view, you're able to see the outflow tract, the subvalvar area, the valve leaflets, which Amitabh had said are thin and pliable. Amitabh, any comments about this white zone just above the supravalvar area?
Yes, that is the confluence. There's a branch pulmonary arteries wherever the branch pulmonary arteries are taking off. As per this picture, the branch pulmonary arteries are of fair sized, but we need to measure it on a still picture. I guess this should be a child of approximately about 1 to 1.5 years. The branch PAs look quite fair sized, and if they are also, the z-scores are okay, plus we need to meet the Magoon's index and the Nakata index. If they are well, then it can prognosticate the post-operative course of the child, that the RVOT pressures and the post-operative course of the child will go on smoothly. If they are smallish, if the Magoon's index is between 1 to 1.5, then the post-operative courses will be very tormentous, and we need to take special care.
So just a word about that whitish area is where usually the valve is tethered. There is tethering of the valve, and the surgeon might need to release the valve leaflets from that particular point of tethering. So you could mention that to the surgeon, but keeping the time constraints in mind, this is, we are trying to move ahead. So you want to describe this view here?
Yeah. This is a long axis view where you can see the left atrium and the left ventricle. There is a large malaligned VSD with the aorta overriding. The first arrow is pointing towards the infundibular region, that is just a subvalvular region with anterior deviation of the conal septum, as Drito said, which is the hallmark of the pathogenesis of tetralogy with the infundibular obstruction. Just above is the valve, which is slightly thickened, not as pliable as in the previous picture, and the supravalvular region is slightly thickened as depicted by the third arrow with the ridge. So this whole RVOT is obstructive and is causing the main pathology of the tetralogy of Fallot.
So probably in this you would say transatrial resection of the muscle bundle. Yes. You can go ahead.
Transatrial resection of the muscle bundle, followed by the valve resection and the transannular patch insertion by the surgeon would relieve the child of the
the patch extending into the main pulmonary artery, which also appears small. So this is sorry about this.
It will lead to a long TAP, long transannular patch.
Yes.
Which in future may dilate if if the patch is loose enough, and might cause RVOT ballooning with arrhythmias.
Right. So when would you suspect there is significant supravalvular obstruction on echocardiography?
Just as in the previous two pictures, if there is a thick whitish ridge just at the place where the pulmonary valve is doming, there is a supravalvular area, and plus there is visible narrowing of the supravalvular area compared to the pulmonary valve annulus and the sinus, then we are sure that there is a supravalvular obstruction in addition. There is the main diagnosis by echocardiography, and also in cardiac catheterization it can be substantiated.
Okay. Briefly about the branch PAs. You want to mention something?
Yes, the commonest ones are usually tetralogy of Fallot goes hand in hand with branch PA obstruction. The commonest one is the left pulmonary artery obstruction due to the flow pattern and nature of the flow hemodynamics. Commonest place is the ostium, where the branch pulmonary arteries, left pulmonary artery is obstructed, which is usually augmented by the surgeon during the surgery. And the next comes the proximal PAs, which can also be augmented by the surgeon up to the hilum. But if it is a long segment hypoplasia of the branch pulmonary arteries, then even after sufficient augmentation, the hemodynamics stands very challenging, because that leads to arborization. The arborization of both the lungs might be anticipated to be lower than compared to a normal one. In that case, the RV pressure, there is a chance that the RV pressure might remain higher even after surgery.
So any comments about the color image that you're seeing here? This is a supravalvular view, a suprasternal view showing the left pulmonary artery. Are you able to see it clearly?
Yes, there is a left pulmonary artery and there is a small ductal flow which is visible. That is, in all probabilities, this child had severe branch pulmonary artery obstruction and the PDA is still patent, leading to some amount of pulmonary blood flow to the child, leading to the increased saturation.
Drito, you'd agree? Okay. So this is the left pulmonary artery. This is another view of the
Suprasternal view. With a, when we rotate it clockwise to see the branch pulmonary arteries, especially the left pulmonary artery, and we can slide towards the left clavicle, so the left pulmonary artery can be visualized in length. Similarly, we can transducer can be moved towards the right clavicle, depicting the right pulmonary artery. Here, there is the best assessment of the branch pulmonary arteries, which are usually 1 to 2 millimeters higher than in the short axis.
Okay, I would like you to comment on this very bad anatomy of the outflow tract in a child who's almost a year old, and this is a subcostal view with the pulmonary valve in this area.
Yes, the whole RVOT is extremely narrow with hypertrophic muscle bundles, the septal and parietal bands, they are very, very narrow here. So the surgeon has to cut it open quite a lot of muscle resection has to be made. The main hemodynamic importance is there might be anticipatory severe RV dysfunction, because there will be a long translunar patch and there will be a lot of RVOT resection. So we have to be prepared in the post-operative period.
So are you all intoxicated with the RVOT? We'll move on to the coronary issues in tetralogy of Fallot, and Dr. Achyut Sarkar is here with us. Sir, why are coronary arteries important in this anatomy as compared to, say, only VSD closure?
Coronary anatomy is important for actually two aspects in relation to congenital heart disease, including the Fallots. One is the coronary arteries may be in the surgical field, so someone can injure the coronary arteries. Second is sometimes it needs a reposition. The commonest situation is transposition of the great vessels, where we need a repositioning. But in our day-to-day practice in echocardiography, when this is not a congenital heart disease, we don't look at coronary arteries. But sometimes this is very important. In a particularly younger child or infants presenting with heart failure, then one shouldn't miss L-kappa. However, in a DCM situation, we look at coronary arteries. But very important is in a young patient, we know that commonest cause of sudden cardiac death in a young patient is next to HCM is a abnormal orientation of the coronary artery in between the aorta and pulmonary artery. So we should be very cautious to look at the coronary artery when a child or a young patient present with syncope or chest pain. So these are the issues when we should look the coronary artery anatomies. Specifically
in tetralogy, let's talk about tetralogy. Coronary artery and anatomy assessment, how does it affect the surgery?
Coronary artery assessment is important from how does one assess, how do you do coronary? So we look at the coronary arteries specifically from short axis view. We keep the transducer, make a little clockwise rotation, and we can look at the left coronary artery system. A little counterclockwise or clockwise rotation, we can look at the right coronary arteries. As it is a very near field structure, so important is we should use a transducer with a high megahertz from 5 to 12 megahertz like that. That is important, and gain setting is very important. It should make a lower gain settings, and the compression should be higher.
So there is no need to worry. There is 2 minutes of time and 15 minutes of audience interaction time which you can take.
Yeah, I thought so. Thank you.
So variations of the, I will quickly go through the variation of the coronary arteries. Fallow is, one is the LAD may, LCA may arise from
I would suggest on the screen, if you can point also the one you're referring to. You want to stand up and do it, otherwise you will sprain your neck.
So one is important, thus the LAD is arising from the, one is the small conal branch that is going in front of the RVOT, that is very important, and another is a large conal branch going in front of the RVOT. These are variations, but most importantly where the LAD is arising from the RCA and going across the RVOT. sometimes we can get a dual LED, that is LED is arising from normal route and another is arising from the RCA. It can be a single RCA or it could be a single LCA. These are the variations.
You want to comment on these?
Yeah. So here the LED which arising from the RCA and going across the RVOT.
And the RCA here. You can briefly see it.
Yeah. You can see the RCA here.
So RCA is usually the wider of the two coronary arteries because it's supplying the right ventricle, and therefore hypertrophic right ventricle makes it a very easily seen artery. And I'd like to mention a few things about the coronary artery anatomy, why its assessment is so important, because if a transannular patch has to be put, that's exactly where the coronary artery is crossing the outflow tract. And if it's crossing the outflow tract and if the surgeon is not aware or experienced, incising the coronary artery will result in an outcome where the patient may not go home at all. So if one makes the surgeon aware that there's a coronary artery crossing, he's going to be aware and not, or rather be careful in the area where he has to do the transannular patch. And that is why the coronary artery anatomy is very critical. And amongst the ones that we have shown you, the critical ones are if there is a dual anterior descending coronary artery, as seen here. So there's an LED from the RCA. This is the MP and the branch PAs here. So the LED crossing, or the dual anterior descending coronary arteries crossing, or the single coronary artery in which the left is arising totally from the right, and subsequently the LED and circumflex also arise from this branch, or the reversal, single left coronary artery. These four are the ones where the surgeon needs to be extremely careful. The most common variant is a dominant conal branch, and we get aware that the coronary artery is dilated, it's possibly crossing, but the conal branch is quite significantly lower to where he needs to incise. So if you can differentiate this from this, that's going to be a significantly important finding. So from the coronary artery anatomy, we move on to other issues, and Dr. Anil Singhi will be talking about those issues, major variations in anatomy and tetralogy of fallow. Dr. Anil Singhi.
Thank you, sir. Dr. Kohli and my co-panelists have nicely described and imaged the whole of the tetralogy. And now I will be going through the common variant. It is said tetralogy is the most common congenital cyanotic heart disease, and it will be good to know all the variants because we will be facing those also relatively more frequently than other congenital heart disease. The most common one, we may see a 3-year-old child diagnosed as tetralogy but having good saturation, like he is pink, and sometime we can see in that echo I am showing the LALV is relatively more prominent with little more flow, like overall pulmonary blood flow is more. Next, sir. So the VHD is bidirectionally shunting, has a left to right component also. More, this is that infundibular stenosis, and this is the variety of pink tetralogy. The patient will have loud systolic murmur, good saturation, and they usually do very well without much symptom, and we can electively close these patients after 1 year or around 1 year of age, depending on the institute's priority. Next. So this same will have a very good pulmonary artery anatomy. You can see a very good sized pulmonary artery annulus, the branch PAs good sized, and additionally in this index case has a small PDA. So overall pulmonary blood flow is augmented by that additional small shunt lesion, and that's the reason he is more pink than other, and this was the reason we were getting little more pulmonary blood flow. So next substrate is absent pulmonary valve, and as we were discussing, no imaging is complete without a detailed history and backdrop information about the X-ray and ECG, and this absent pulmonary valve can be diagnosed even without putting the probe on the patient's chest. Big aneurysmal branch pulmonary arteries with a reduced pulmonary blood flow, you can see the paucity of the blood flow in the lung. With clinically, if we put the stethoscope, we'll get a loud systolic ejection murmur as well as diastolic murmur. So it will be an EDM plus ESM in the left second space or around. So possibly with a second heart sound single. So we were almost with certainty tell this we are going to deal with a absent pulmonary valve. In the echo is a very classical, we cannot miss that. If it is like this is that RVOT, you can see significant obstruction, and this is as a point obstruction. Maximum obstruction happens in the annular region. We can see here 106 was the gradient in that index case. PA sizes will be very big, both MPA and branch PA depending on the age of the child. And this type of patient, if they are in the infancy, will have significant respiratory component because of the obstruction of the bronchioles. Another example, again, this is absent pulmonary valve, and you can see 1 point obstruction where we are getting free pulmonary regurgitation along with significant obstruction.
So pulmonary arteries are dilated in these
yes,
cases?
and so these patients require reduction pulmonary plasty, Dr. Amitabh was mentioning, because of the aneurysmally dilated PA. So we need to tell surgeons how big and all the details. So this variant is another interesting variant for tetralogy. And the third one, we were discussing this variety, the conal septum anterior deviation is the sine qua non. But this conal septum can be deficient, and we will get the turbulence happening bang on the annular region. So this is, we are seeing little bit modified view. This is the aorta, this is the pulmonary artery annulus, and this is the VSD immediately below the pulmonary valve. We will see the turbulence. This variety is also called the doubly committed VSD, like Mexican variety of tetralogy. They will be having obstruction in the annular level, and they usually end up in having a transannular patch, though the obstruction not in the infundibular region. So the third one is that, before that, sir.
Sorry.
So tetralogy and AV canal is always very difficult substrate of the tetralogy. You will get common AV valve, inlet VSD, primum ASD. You see here we are seeing an unbalanced AVSD favoring right side with RVH. Just some measurements just to say this is an unbalanced AVSD. Next please. And we are seeing in the subcostal short axis, this is the common AV valve. This is the RV outflow, this is the obstruction with a significant gradient. So we are dealing with tetralogy of fallow with a complete AV canal unbalanced, that is also called as TET canal, more commonly seen with the Down syndrome patients, and the repair is little difficult than a regular tetralogy or AV canal because of both things same time present in a Down syndrome type of patients. This index case also had an interesting co-association, which is because of the AVHD possibly. We are seeing a bilateral SBC with the LSBC coming to the roof of the LA, and surgeons need to take attention to this fact also, because if he repair only this without taking care of the LSBC roofing, the child will be significantly cyanotic even after the surgery. So lastly, just to tell in 3D, we can see both the anatomy, if we are lucky, in a single plane. This is a subcostal in-face view. We are seeing this is the tricuspid inflow, this is outflow, and this is that aorta behind, this is subaortic VSD, and this is that anterior deviation of the septum and that obstruction. So this is just to have an idea. If we get a good 3D in-face, we can tell surgeons where exactly the VSD is located, and it will help in the planning of the surgery. Thank you.
Right. I'd like to thank the panelists here for a wonderful job they've done, and I hope they've kept you awake, which is sometimes can be a challenge with congenital heart disease. So next time you're referring a patient for tetralogy repair, don't just write TOF repair. Please clearly mention transatrial VSD closure, transatrial infundibular resection, possibly also through pulmonary artery, and if you feel that the Z score of the pulmonary annulus is less, please do mention small transannular patch. And that's going to give you a patient whose post-op echo is going to look like as if it was a VSD repair done, and you'll start looking for things which will indicate that it was not just a VSD but for tetralogy. Otherwise, with a long patch in the outflow tract and in the RV incision, you see massive, severe pulmonary insufficiency in RVs dilated few days after the repair is done. So with that background and information, we open the discussion for the audience, and I look forward to some questions.
If I just can start one question,
Yes, yes.
that is most commonly faced in the clinical scenario, that we are doing the nice echocardiogram, still we are not happy, and what are the indications when echo is not enough in a given case of tetralogy of Fallot?
So I'll add another element to that. Before even you echo, which is that patient who would require an angio also? You've not put your echo probe on the patient, you've seen the patient, you know his age. So at what age you would say, oh, I need to definitely do an angio also in this patient?
So the adult bigger patients where we are not very sure about that RV anatomy or the coronary anatomy, whether coronary is crossing across or additional VSD, those are the patients who definitely will get benefit by doing a thorough diagnostic cardiac catheterization to delineate all those features so that surgeon can plan the surgery very nicely.
So the PCSI, the Pediatric Cardiac Society of India, suggests that beyond 7 years of age, one should consider doing an angiogram if the patient is deeply cyanosed, because you may need to deal with the MAPCAs at the same time, apart from delineating the anatomy in detail. So the rest of the anatomy can be assessed by other modalities also, including CT angio for pulmonaries, but you cannot assess MAPCAs or treat the MAPCAs significantly. Is that right?
Yes.
Okay. And which other patient you would want to do a CT angio?
If you have already added these patients with suspected MAPCA, patients who do not have that much antegrade pulmonary blood flow in the echo, but they are saturating well. So definitely there are multiple MAPCAs which we are unable to visualize from the suprasternal or other views. They definitely are of having some benefit with giving a nice CT angiogram.
Drito, Amitabh, if you suspect branch pulmonary arteries. No, go ahead. Both of you.
For the branch pulmonary arteries, suppose the branch pulmonary, because CT scan is always dependent on the forward flow. So even if the branch pulmonary artery is not seen on CT angiogram and we are doubtful about the existence and the size and caliber of it, then there is a role of cardiac aspiration and a retrograde pulmonary venous wedge angiogram to delineate the branch pulmonary arteries whether they are present or not. Because if the origin is cut off, for example the LP is cut off, then still we have some hope.
Yes.
Amitabh, Drito.
Post-PT shunt patients also probably I will go for a post-shunt patient also probably I will go for a CT angio too, because there is a chance of pulmonary artery distortion and stenosis in post-shunt patient.
Audience question.
Sir, would you say something on coronary artery fistula?
Coronary artery fistula.
Yeah.
Well, coronary artery fistula in tetralogy, is that your question? Okay, I will refer to tetralogy only. So, have you seen coronary artery fistula in tetralogy?
Yeah, I saw one case, and this is extremely rare. They behave like a MAPCA. So those patients will be less cyanotic than the regular one, but that will be multiple small fistula rather than a big fistula going to the pulmonary arteries. So that's that case, or whatever I have seen. Major one, if you have seen, you can tell.
It is more common possibly after surgery.
Yes.
After surgery, you often see that there are small coronary branches have been cut during resection of the RVOT, and you find there is some continuous flow coming in the RVOT in the post-operative period. Those are small coronary arteries which have been cut during the muscle resection, and they usually does not cause much problem. They are just small coronary branches.
If there is a
that will only be seen in the pulmonary artery or in the other part?
No, in RVOT you will see the coronary fistula post-operatively because they've resected so much muscle.
There is no history of operation, but still some flows are there in the pulmonary artery below pulmonary valve, and hopefully they are arising from the left coronary artery. So would you call it as coronary artery fistula?
In congenital heart disease, you can see any combination. You have to be ready for it. Definitely, we'd like to look at the images if you have some after the session. Any other questions from audience?
Sir, in the case he is referring, there is one, you have to be particularly cautious about one thing. Tetralogy of Fallot is a cyanotic heart disease with the myocardium receiving deoxygenated blood. If you have a pre-existing coronary cameral fistula which is large enough, then there will be more diastolic runoff. That will already lead away whatever muscle oxygenation is getting, the muscle is getting, that will further eat away from it. So post-operatively there may be yet more RV dysfunction or even LV dysfunction.
Any preoperative coronary artery fistula on cardiopulmonary bypass has to be corrected. Has to be corrected. Yes, sir. Yes,
MRI is required to your...
So, Dhrito, when is MRI required?
The same for the CT? As
One question, sir. For the audience only.
Yes.
The views which everybody must use to gather the maximum amount of MAPCAs that are there, which is very essential because the MAPCAs have to be closed before surgery. Most of the echocardiographers see one MAPCA, two MAPCA, but all the MAPCAs they do not plot. So can you enumerate on the views that you should take so that the common echocardiographer...
I'll just make one, we'll come to that. We were just on the MRI, but we'll just subsequently come to that. MRI post-op MRI. Post-op MRI we'd like to do.
If there is, what happens in case of usual tetralogy repair, there will be a transannular patch or there may not be a transannular patch. So if there is a transannular patch, then there is usually a significant pulmonary regurgitation. Often it is a pre-pulmonary regurgitation. Sometimes surgeons put a pericardial or some artificial graft to put a monocasp to reduce the pulmonary regurgitation, but in the long term most of them are ineffective, and this long term pulmonary regurgitation causes right ventricular dilatation. Now there is by echocardiography to check the right ventricular volume, to check the pulmonary, how much is the exact pulmonary regurgitation.
We are short of time,
amount,
you'll have to hurry up.
And how is the right ventricular function. The main role of MRI in these post-operative particular cases.
Pre and post-op MRI in tetralogy is basically only in one situation, and that is the modality to assess, that is RV volume assessment in late post-operative tetralogy 10 or 20 years later, to see if the RVs reached a point where we need to intervene. Now going back to MAPCA's question, so suprasternal view is the one we need to look at for the MAPCAs. Any other suggestions?
Subcostal short axis also, if we can see, can show the whole of the aorta, and we'll be able to see MAPCAs are coming. That much should be enough. If we are seeing these views, we have suspected, so the next part anyway is going to be dealt by CT or angiogram. So suspicion is more important than exactly telling there are 3 or 4 MAPCAs. Sir?
Are we done? We have a bit more of time. Any other questions? We don't have any more questions.
Thank you, sir.
Thank you. It's been a pleasure. Thanks to the panelists. They've done a great job.
Thank you very much.
Thank you, sir, for such an interactive session. I would like to request Dr. Achyut Sarkar to kindly felicitate Dr. Vikas Kohli.